Welcome, everybody, to another podcast from Hotel Technology. And today I'd like to welcome Professor Sam Shah. Hello, Professor.
Hello, thanks for having me, Stephen.
Absolute delight. Thank you very much for joining us today. Professor, I wouldn't mind if you started telling the audience a little bit about how you ended up where you are today by describing your professional background to this point in time.
Well, that is certainly a difficult question. One of the things that I've really done to get to where I have is almost had no plan at all. I think the earliest plan I probably had was to undertake the study of dentistry. And very soon, as I sort of did that, I realized I had lots of other interests. So as time went on, I diversified and I worked originally in retail technology and financial services technology. Then I studied dentistry, worked in primary care, then went into a hospital role, followed by public health, then consulting, converted to law, and then brought all of those things together by working across the NHS in a number of roles spanning urgent emergency care, education and training, and then latterly digital health, digital development, digital technology, which is probably where I spent most of my time over the last 10 years, and combining that with academia, clinical practice, and working in startups and scale-ups.
Speaking of startups and scale-ups, you're currently the Chief Medical Officer for Numan. Can you tell me something about that, please?
Yeah, Numan is a men's health company. So Numan is an online men's health company. So we operate in the digital health space. And we are both a healthcare provider, but also we develop technology as well. So we are ultimately a health tech provider, but we are an online health tech provider and providing digital health services. And the way that works is patients come to us online, and most of our work focuses on men, but we are open to treating women where we can as well. And ultimately, people come to us, they complete an online consultation, they get to have a consultation with one of our clinicians, after which we make a treatment decision, and then we support patients. And I guess where our model in Numan is slightly different is one, we're direct to consumer. The second part is that we are not a publicly funded service, it is directly self-pay. But most importantly, we treat people for conditions where they might struggle to access services elsewhere, and things where there's stigma attached, things where people may prefer a digital model over physically seeing somebody.
How do you measure the efficacy of the service that you provide?
It's really interesting. And if we weren't a digital provider, I think it'd be more difficult. And I think this is difficult for all providers around the world of healthcare. But if I take something like an area like weight loss, weight management, one of the more sort of simple ways of doing it is we track people on their sort of outcomes. So as people are using our service, we will over time have interactions with coaches, with clinicians. We're able to understand people's experiences, but also some of their biometrics, where they are having blood tests, for example, we can see the change in their blood biochemistry. And most importantly, for something like weight, we can see a change in someone's weight over time. So it's difficult, but certainly with the digital health model, it's easier because we can use apps to support people with tracking where they want to.
So it's really providing a registry. Is that what you're doing?
Not really, but if I think of traditional registries, typically registries offer a way of collating individuals with a particular disease. But what we do is we treat a number of people who are our patients, our members of our service. And over time, for some of those, where they choose to, we will have data about them because they provide it to us, where we can actually monitor those outcomes. Now, this is interesting because it's quite rare in physical services that this happens. And where it becomes even more interesting, and certainly for colleagues in medtech and pharma, that it becomes much easier to run things like decentralized trials, for example, because you have a curated set of patients that all might share certain characteristics. It's an easier way of collecting data about individuals in an ethical, safe way, and really understanding the direct effect and benefit or detriment of any treatment that's provided to somebody.
That's interesting. So what do you think the challenges are in digital health today, particularly in the United Kingdom? I think we should talk about.
Well, the challenges globally actually aren't that dissimilar. Certainly, if I think about the countries I've worked with in the last 5 years, whether that happens to be Saudi Arabia, UAE, Canada, Israel, France, Germany, Australia, and the UK, the challenges certainly aren't dissimilar in any of those at a macro level. But so if we look at the UK at a micro level, there are lots of challenges. The first ones, of course, are that there's not enough healthcare workforce in the UK. Now, on the one side, that could be a driver for digital health. On the other side, you've got the problem that, well, there isn't enough workforce. Therefore, there's not enough capacity to train that workforce. And if we can't train that workforce, we can't give them the digital health skills to impart either with their own patients or to support patients in actually using digital health tools. Then you've got the resourcing problem in the United Kingdom, where in the United Kingdom right now, the entire of the National Health Service, which is the dominant health service in the UK, is running in deficit, certainly in England. And that means there isn't really any space to pay for digital health. We've got a fairly confusing regulatory framework. We've got next door to us, Europe, which has its own framework for the use of medical devices and technology. The UK that's adopted and adapted some of that, but unknown whether it will stay consistent in terms of the regulatory environment. Then we have localized regulation for the NHS itself, clinical safety regulation. There's the advent of cyber that makes it more difficult to launch digital health products because this is a factor that is costly to deal with. And then the biggest one, reimbursement. Globally, of course, we know there are two extents, reimbursement models. The WHO only yesterday shared their position paper on this, and I think every single country bar one had some form of reimbursement yesterday described, or most recently described around that. However, the United Kingdom doesn't really have a true reimbursement framework for digital health. We have methods of evaluating products. We're very good at coming up with evaluation frameworks. We've got a regulatory model that could be applied. We've even got a decision-making body around the cost effectiveness of digital health products. But when it comes down to reimbursement, that is a localized decision. And a localized decision on something reimbursement is very difficult for innovators, pharma companies, and anyone trying to launch a digital health product or system. So there's some of the challenges. The other one for the United Kingdom is it's not one thing. There are 4 nations, and those 4 nations have 4 different sets of regulations. You have regulation at a macro United Kingdom level. You have a regulation at an individual user level, so for clinicians using this technology. You have state level regulation in each of the 4 nations for healthcare providers using digital technology. And then when you get a level below that, the guidance that is used to enforce that varies. So when you put this together, the United Kingdom on the one side might be a good place to ideate and innovate, but in terms of launching products, bringing them to market and adoption and reimbursement, it's not great.
So shall we talk about pharmaceutical companies and their relationship with digital health? Because from my opinion, or from my outlook on life, I always thought that would have been a great partnership. Would you agree?
I think it certainly is and could be a great partnership. But pharma companies have a difficult space they operate in, a highly regulated environment. That means their propensity for risk is low. Understandable, especially when we look back at history of pharma companies in clinical trials, regulated clinical trials, bringing drugs to market, avoiding danger to citizens and patients from the things they produce, and operating within all the guardrails the pharma companies do, whether it's sort of international level pseudo regulation or country level regulation. These things shape pharma companies. They color pharma companies and the way they operate in an environment where compliance and risk probably trumps everything else. On the other side, we have the fast and furious world of digital health, moving quickly at pace. Agile comes up every single day, and this is very different to the environment of pharma. So you put those two things together, how do they reconcile? How on the one side do you have these humongous organizations like pharma companies, some which are big, some which are small, but used to operating with a high degree of compliance. And on the other side, digital health companies that are often coming more from the tech orientation, they're used to operating very quickly. So bringing these two things together is really hard. And I can see that challenge itself makes it difficult. Now we can see this. If we look at the spin out of something like Haleon from GSK, I'm yet to see what it's actually brought to the market in terms of actually changing consumer access to pharma, medtech, anything else through digital health. It's got some great ideas. It's very supportive. They put out some good position statements, but I'm yet to see any outputs that actually really allow digital health adoption for consumer. They're not the only ones. Every single pharma company I've probably spoken to in the last 5 to 10 years wants to do it. They have the appetite. They're engaging on the topic area. They have entire teams doing this. But what is it they're actually going to produce that brings together citizen, device, software, and medication? Well, we haven't really seen this move very far. Now, on the one side, it could be because not all governments have got models for digital therapeutics. On the other side, it could also be because our starting position is coming from pharma and medical and medicines regulation, as opposed to software and production of technology.
That's fantastic. Thank you very much for that insight. I quite enjoyed that. Could you provide me with some case studies that you've been involved in digital health that have been successful?
Well, there's lots of case studies that I've been involved in over the last few years around digital health. But I'll start off with a few that I think have been particularly useful and helpful. The first one was the creation of what in the UK we call NHS 111 online. Prior to the existence of NHS 111 online, everyone had to phone the national helplines for urgent care. This was problematic. It meant that phone lines were blocked up, lots of people were waiting. At the end of the day, having a triage online, only then to find they're then stuck in another queue. Now, those queues haven't gone, the workforce problems haven't changed. But one of the things we did was test and try different clinical decision support systems that users, citizens, could drive themselves. It's a fairly long program, but at the end of it, we came up with a position where nationally in the NHS, certainly when I was part of it, we launched a product called NHS 111 Online, run by the state, produced by the state, by the NHS in England, and that still operates today. That allows citizens to go online, have their symptoms triaged, and then be referred in to a service if that's relevant for them, or given some instructions on signposting that helps them get to the right service without having to necessarily phone those helplines and wait in queues. Of course, that's not the only answer, but it certainly has been successful as a way of changing things. And it was that technology that during COVID was used by many people to assess their COVID symptoms during the COVID outbreak globally, but of course in the UK this was used. So that's one example of something that was quite useful. There are a few others there as well. And one of the other ones that I do like to think about is digital primary care. Digital primary care has different meanings in different parts of the world. But in the UK, I think of it as telehealth that's being used in a primary care environment. Now, many people that I worked with collectively came together to work out how do we launch a digital primary care service. And there were some new players into the market that were really struggling between 2016 and 2017. And one of the things that we did is come up with some standards with a set of regulators, and then a commissioning framework, and then a mechanism of actually allowing those companies to come forwards and enter the framework, which then became used in the National Health Service in the UK. So that was another example of digital health being used to create an access mechanism, helping patients avoid having to go in to regular physical settings, but use online mechanisms, whether it's an online consultation form or other forms of telehealth, to connect with their primary care, their family physician in the UK.
I wouldn't mind if you talked about Numan and the weight loss program that you've introduced as well. Would you mind doing that?
So at Numan, we have a weight loss program. And this has been quite interesting because we've been trialing it with the use of semaglutide that many people might know. So semaglutide is a drug that mimics a drug that already naturally exists in our bodies. So GLP-1 receptor agonist is the particular protein molecule that is mimicked in semaglutide. And what that does is it basically helps the feeling of fullness and appetite suppression. And what we've done at Numan is work out a digital health model of deploying this. Patients come to us at Numan and they have an online consultation. So first of all, they complete an online form, which gets reviewed by our clinicians. That results in a decision as to whether or not that patient may or may not be suitable for treatment. Now, it's not that straightforward. There's some interaction with the patient to work out some other factors that they may not have covered in their online consultation. But at the end of it, Some patients are eligible for treatment, and we make a decision that they should have treatment, and we offer them treatment using semaglutide, which is now commonly known as Wegovy. So the medication goes out to the patient, and we then use a digital route through which we explain how to take the medication. But we combine this with a lifestyle program, which is delivered by coaches. And the coaches use our app to connect with patients, and through that, find out a little bit about them, help support them with their diet, their exercise, and modes of behavior change that will help them sustain new behaviors. And we believe that a digital health model in this way is more conducive to change, because patients can use this model in their own time in a way that suits them, and hopefully it's less invasive. These are difficult conversations to speak about weight. They come with stigma around body image, things that people don't necessarily want to talk about. But by having a digital health model, it means that people can interact when they want in a way that's comfortable for them, using language that suits them. And at the same time, they get a response from our team, our coaches, our clinicians, and others over time. So this is the model we use. Now, the reason that we think that a model such as this is more conducive to change is, one, it's more accessible, but two, it's also delivered in a way that is sensitive to the language, the image that people are comfortable with in terms of the discussion they're having, but also the way in which we approach it. It's not really coming from a sort of very medicalized perspective, but more around the human and emotional aspect of what people go through.
I've actually put two friends of mine onto your program, and it's been immensely successful for them. And I congratulate you on what you've achieved there. Is there anything else that you'd like to discuss or we should be mentioning in this podcast?
I think one of the things that is worth talking about is where we are globally on data sharing for digital transformation and health. This is a really difficult area, because on the one side, we have lots of data being transacted in healthcare services. If we imagine right now, there are something like 1,400 device interactions that any one of us have any day. Increasingly, of those 1,400 interactions a day that we have with devices and technology, more and more of them relate to our health as individuals. Predicted that by 2025, we'll have 5,000 device and technology interactions a day, more and more of which will be coming from devices taking biometrics, health data, well-being data. Now, the challenge is, where does that data go? How does it get shared in a safe and ethical way? And how does it get used for the benefit of citizens, the public, and creating new products and services that we can innovate off? This is not easy for any government. And some of the problems we're facing are things like, where is the data stored? The whole issue of onshoring and offshoring. On the one side, countries around the world want data to be stored in and around their own shores. On the other side, they want to innovate and work with companies, be it pharma or otherwise, that may exist in other places. So how do we reconcile that the user, consumer, the processor of the data might be in one jurisdiction and setting, and the data and the citizen, the patient, might be in another setting? But to get the benefit to citizens, we have to work out how we traverse these lines. On the other side, there have been data scandals around where data has been shared in an inappropriate way. So how do we produce guidance, rules, regulations that on the one side protect citizens, but on the other side allow safe sharing? And these are some of the big challenges we've got right now that face us in health services. They're not the only ones. We talk about data all the time. Some people talk about data as an asset, other people talk about data as a commodity. I suspect data is an asset, but it's the use of it that probably is the commodity. But to get there, we need systems that collect, store, utilize data in a structured way. But at the moment, structured data may not exist in the same structure. The language might be different. I don't mean the language that's written in, but the language in which it's stored in, it's coded in. So as we've got different health systems around the world with different electronic patient records, different storage systems, we need some consistency in that if we're really going to see the benefit of data at scale. But then there is the homogeneity of data. This data classically exists in systems that are already well developed. Classically, they're in the Western world. Most of that data will relate to a Caucasian population. But if we look at the heterogeneity of the populations in Africa, in the East, in other places, we are missing out on that richness of that data, which when brought together will allow pharma companies, med tech, others produce and innovate new digital health products and services, which we're currently missing out on, which could have a benefit to citizens. So we have problems, not only about where the data is stored, where the data is shared, how it's processed, but also the type of data and how we encourage people around the world to both give that data in a safe way, but also how we allow digitization to take place so that the data can even exist in structured form.
That's fascinating. Thank you very much. Well, I'd like to thank you very much for your time today. And I'm very grateful that you've done this. I'm quite impressed with your background, as you know. I'd also like to ask you, where are you currently practicing as an academic?
So I work with University College London, UCL, in the Global Business School for Health, where we run programs. We have an MBA program, a digital health entrepreneurship program, amongst some other programs. I also work at the University of Central Lancashire, and where my chair is the College of Medicine and Dentistry, Ulster University. So we're with 3 organizations spanning digital health that covers everything from computer science through to clinical medical services.
Extremely impressive. And thank you very much for your time today.
It's been a pleasure joining you. Thank you.